Thank you, Dr. Thase, for speaking to simple and practical mental health. I appreciate it very much. So first I want to jump in by asking you, why is this Cipriani et al. Meta-analysis that was just published in Lancet, why is it receiving so much attention, in the medical websites as well as in the public?
I think there's an aspect of people being starved for some good news about our treatment. It's less than 10 years ago that there was widespread questioning about whether antidepressants even worked at all, or whether their clinical benefits were above marginal or not very important. And I think in part the Cipriani paper, because it does include a meta-analysis versus placebo, demonstrates that a large number of antidepressants have substantial efficacy in comparison to placebo. I think the other thing that's newsworthy about it is that part of the notion that antidepressants didn't work very well was that they were all interchangeable, that one wasn't more useful than another. And basically this suggests a lack of specificity, when in actuality there's been evidence all along, going back to the tricyclics and monoamine oxidase inhibitors, that there are meaningful differences between our antidepressants. They may not be as large as we'd hoped for, but they've been there since the 1960s.
Right. So both that antidepressants are more effective than placebo, and that there are differences between the antidepressants. Both are attract attention. But could one, if one was determined to be skeptical, could one not say, well, if you analyze it one way, it looks like there's not much difference, and they analyze it another way, it looks like there's a big difference?
Well, so there is some beauty in the eye of the beholder here.
Yes.
And the notion that people like Kirsch and others have said is that the difference is small, the absolute difference is small. And there's nothing in the Cipriani paper that detracts from what Kirsch has said. On average, if an antidepressant is going to deliver about 55% in a study, the placebo in that study probably will have delivered about 40%. And so the average drug placebo difference is modest. But we don't treat people with placebos in our practice, and when we treat people, we get all 55%. And in fact, if we're good at treating people, maybe we get 65%, because how you take care of people has a lot to do with whether they stay on the medicine and whether they get better or not. And that, of course, can't be parlayed or can't be properly assessed in placebo-controlled trials. I think the other thing is that most of this literature comes from the pharmaceutical industry and the bare bones basic studies that are done in order to bring their drugs to market. And these studies are designed to answer a simple question: does our drug work well enough to be sold? And is it safe enough to be sold? And the studies are fine for that purpose, by and large, but they don't help us answer more important questions like, is one drug better than another for certain patient populations? And there you've got to do special large studies, which currently aren't being funded by the National Institute of Mental Health, or make the best you can with the meta-analyses by doing these large group comparisons. And that's where a labor of love like the Cochrane collaboration has done with this paper, and did 8 years ago with an earlier set of data, does help us make kind of comparisons about drug A versus drug B. Now, these studies fall short also because you often can't do specific patient subgroups. And of course, as clinicians, we're always interested in, is this better for women? Is this better for older patients? Is this better for people with more severe symptoms? And so forth.
Those questions cannot be yet answered by this paper.
No, you need the individual patient data from all these studies in order to begin to do these patient-level meta-analyses, and then you can begin to do some answering of questions. People have, there's this anti-scientific notion that you can't trust meta-analyses, and some healthy skepticism is good if the results of a meta-analysis are counterintuitive and aren't consistent with your clinical experience. Don't automatically assume they're right, because the meta-analysis should basically simply be the average results of all the studies weighted for the size of the studies. So if your clinical experience is consistent with the studies, no doubt the meta-analysis will confirm it. If the meta-analysis gives a discordant
Yeah.
conclusion, something's wrong, either in your own practice or in the conclusion coming from the study.
Right. But what about network meta-analysis? Well, that seems like a special case. We are all pretty comfortable with meta-analysis of randomized controlled trials, but here it's an indirect comparison, and that makes me more nervous because, across decades, across continents, across age groups, how do you view, do you take the results of this network meta-analysis roughly as seriously as you would take a regular meta-analysis, or are you more skeptical about this?
I have less faith in the network meta-analysis than in meta-analysis of direct comparisons. But you need a large number of direct comparisons before you can start to have confidence, like at least 10 or 15, unless there's a clear difference. Just for example, if you were trying to say, does mirtazapine make you more sleepy than an SSRI? Just to pick an example, you probably need a meta-analysis of 3 studies in order to conclusively because this is just a clear fact. One drug does it 25% of the time, the other class of drugs does it 3% of the time. Right. But when you're talking about the difference between, say, 10% and 6%, you've got to have a large number of studies to begin to parse this out. So the thing about the network of meta-analyses are that they're kind of like the way we play fantasy football, or the way you do Monte Carlo simulations for other kinds of projections about healthcare utilization and so forth. The more data points you have, the more reliable your summary conclusion will be. And when you don't have many comparisons, the indirect conclusions can be less confidence inspiring.
So with regard to this specific paper, are there serious problems with this paper that you are concerned about?
Well, so in my own practice and in work I've done myself, I've already knew that several antidepressants were more effective than fluoxetine, and this included venlafaxine and mirtazapine on head-to-head comparisons, and it likely included escitalopram being more effective than the SSRIs as a class, and probably a few other comparisons. We all knew that reboxetine was not such an effective drug, and there are a few other things. And in the 2009 version of the Cipriani meta-analysis, most of these conclusions were there already. So the one new finding that I'm a little worried about is the assertion that vortioxetine, or Trintellix, is significant in the significantly more effective group of drugs too. There is a study where vortioxetine was more effective in switching from SSRI non-responders than another antidepressant, agomelatine, but there are also a fairly large number of comparisons of vortioxetine with SNRIs, duloxetine and venlafaxine. And of course there have been no comparisons with vortioxetine against fluoxetine. So the very kind of pillars of comparison here are missing. And so I worry about this. And I use vortioxetine in my practice. I wish I could use it more. Its formulary position keeps me from using it more often. But I don't have, either on my own reading of head-to-head studies or clinical experience, I don't have the sense that it's actually among the most effective antidepressants, only that it's different enough from the SSRIs to be used.
So there's no really solid reason to believe that vortioxetine is more effective than other antidepressants, except agomelatine, which may not be very effective.
And agomelatine's not available here, so and I'm pretty sure that the other active comparator was one study using escitalopram versus vortioxetine. So it just hasn't been extensively compared against the other drugs that we often use in daily practice.
Right. What about the concern that I expressed the concern that in the Cipriani et al. Paper, many findings that were not statistically significant are nevertheless listed as conclusions. So, for example, agomelatine is listed as being more effective than other antidepressants, while it wasn't really more effective than any of the SSRIs or SNRIs.
Yeah, these guys are usually pretty rigorous in this, and I've seen them on occasion actually explain away statistically significant findings, saying that they're not clinically meaningful, because when you have a large
Yeah.
group of data, sometimes you can say, I can tell you that Dutch men are on average taller than men from the United States, but what on earth does that mean? Because the difference is this much, it's not meaningful. So I don't really understand that. And so
Yeah.
the mirtazapine, venlafaxine, escitalopram findings are based on large numbers of head-to-head comparisons. Those are rock solid. The agomelatine one, it's not there.
Right. So can I put you on the spot, Dr. Thase, and ask, like, after reading this paper, the fact that this paper has published, has it changed your clinical practice in any way?
I pretty much already focus on using first the more effective antidepressants and tend to give kind of double credit to escitalopram because it's one of the more effective and it's one of the better tolerated. When I need a stronger antidepressant, I will usually go to venlafaxine unless the patient also needs to sleep and I don't worry about weight gain, and I go to mirtazapine. And in my practice, I wish I could use vortioxetine more because it does have these unique possibly cognitive enhancing effects, but I can't get it because I'm not allowed to possess samples, and patients' formulary benefits often won't cover the drug. So sadly, although I'm strongly in favor of clinical science and a meta-analyst myself, I'd have to say that this paper has confirmed most of the things I do already in practice, not changed my practice.
Not necessarily new findings.
Yeah.
Thank you.